Good afternoon, Jamaica. Good afternoon, New York. Welcome to the program. This is Jamaica Live. We're on Bridge 99. I'm Bruce Golding. We do it every Monday. Start of a new week and a new program. And a program, as you know, we try to focus on serious issues on this program. We delve into them. We don't try and deal with more than one issue in any program because we want to treat with it as much in depth as possible, in the hope that those of you who are listening can, have a full understanding of the issues, all of the parameters, the challenges, the difficulties, and form your own opinion. And we invite people to discuss these issues with us, people who we believe can bring value to those discussions. So that's what we are about. It's Jamaica Live. We're on Bridge 99. An issue of major concern to most of us is the cost of health care. It is a cost that we have to contend with from the womb to the tomb. We are living longer these days. In the last 30 years, those persons who are 60 years and over, that population has increased by 50%, although the overall population has increased by only 15%. And as we get older, just like a car, the body needs more maintenance and more frequent repairs. We run into various problems: diabetes, hypertension, heart problems, respiratory problems, eye problems, not to mention cancer, liver disease, kidney malfunction. Our lives, as we get older, increasingly depend on medical treatment and pharmaceutical drugs. In many instances, we have to rely on them for the rest of our lives. But healthcare is expensive. Surgery, if that's what you need, costs a lot of money because it has to be performed by well-trained and highly skilled doctors and nurses who have to be paid a reasonable sum, because if not, they will pick up themselves and go elsewhere. Medicines cost a lot of money because the pharmaceutical companies that manufacture them have to spend vast sums of money on research and experiment before they can get approval to put those drugs on the market. And one of the reasons why they cost so much is that very often when they spend that whole heap of money to do the research, it ends up in a failure. And they have to start all over again, having spent so much money. So when they do eventually develop a drug that is successful, they add on all of those costs of the failures into the one that succeeds. And we end up at the pharmacies having to pay that high cost. So it costs a lot of money to treat the kind of illnesses that are so prevalent here in Jamaica. Let me get very personal about this. I'm 75 years old. And the tablet that I have to take every day to control my blood pressure, which is something that runs in my family, and then the anticoagulant tablet that I also have to take every day to prevent me from developing blood clots, which is a problem I've had in the past. Those tablets cost me almost $30,000 a month. If I also had diabetes and heart problems, as many people do, it probably would cost twice as much. How many people in Jamaica can afford that? Many people don't even earn that much. So what do? Some of them die for lack of medication. Some take it when they can afford to buy it. And you know what some do? The tablet that they're supposed to take one every day, they cut it in half, and then take half today and save the other half for tomorrow to try and stretch it. The government shoulders a big part of the burden of providing health care to the general public. Last year, the government spent through the Ministry of Health $70 billion, 70 billion spelled with a B, to provide free health services to the public through our public hospitals and clinics. 10 billion of that 70 billion was spent to provide medicines free of cost. Free healthcare is an issue that has been the subject of some controversy. Public hospitals used to charge user fees to augment what was provided in the budget. It was done on the basis that those who could afford to pay should pay something toward the cost of the services or medicines, even if that covers only a small portion of the cost. Those who were unable to pay, they just didn't have it, would not be charged. That's a logical argument. The trouble was that it is not easy to administer that system in a way that ends up with people who really cannot afford to pay being denied the services that they may need to save their lives. And that was what motivated me when I was Prime Minister to abolish user fees at public hospitals. Because what we used to do, we employed people to interview each patient. Each patient had to register, and in the process of registering, you were interviewed so that they could assess whether or not you could afford to pay. That assessment couldn't be done purely by interviews, because in some cases, they visited the person's home to see where they lived and how they lived, how many TV sets they had in their home, what size fridge they had, how much furniture they had in the home. Not only was it a clumsy process, but it was time-consuming. By the time they did all that, the patient may well have died. And I remember one lady who was diabetic and had to have one of her legs amputated. And she was given a bill for over $50,000 for the cost of the surgery and the 6 days that she spent in the Spanish Town Hospital. I was the MP for the area. And when I heard about it and she complained to me, I went to her house. She lived in a one-room shack. The floorboards were rotting. She had no fridge, no TV, just an old rickety bed and a small dining table in one corner of the one room. She had a coal stove at the back of the house, and she used a pit toilet. Yet she had been assessed as someone who could afford to pay, and she was handed a bill for over $50,000. I am sure that that woman never saw $50,000 in one bundle yet. But, they were hounding her down to pay this bill. And I remember when I was in office, I asked the officials at the Ministry of Health, having determined who can afford to pay and the amount they are supposed to pay, how much of that amount was actually collected. And I was told about 17%. Now, I'm sure some of them could well have afforded to pay, but just didn't bother. But many of them who didn't pay because they just didn't have it to pay. We were probably spending more money to employ people to assess who could pay and prepare the bills than the 17% we were collecting. But removing user fees does not solve the problem. The provision of good health care, good quality health care, needs more money. More money than the government can find to put in the budget. Where can that money be found? For a long time, we have been exploring the possibility of a national health insurance scheme that would enable every person to access health services and medicines at affordable costs. Something like Medicare in America. It is a system where, through salary deductions, people contribute to a fund that is used to meet the cost of providing those services. We do have private health insurance in Jamaica. Companies like Sagicor, Guardian Life offer a variety of health insurance plans. And we hope to speak with Mr. Chris Zacca, the president of Sagicor, later on today. But the majority of Jamaicans are not able to afford those plans. Most of those who have private health insurance do so as part of their employment benefits through salary deductions and employer contribution. The issue of a national health insurance scheme got some momentum when the government in 2019 tabled a green paper on this subject, outlining the concept and identifying the issues that would have to be dealt with. What are those issues? How feasible is such a scheme? How soon can such a concept become reality? How do we ensure universal coverage? In other words, how do we ensure that everyone, including the person who is unemployed, the small farmer up in Matney, on the border of Clarendon and St. Anne, the sidewalk vendor in Crossroads, the household helper, the fisherman in Alligator Pond, how do we make sure that everybody is covered? That's what we're delving into today. And we're going to be talking with Minister of Health and Wellness, Dr. Christopher Tufton, as soon as we come back. Welcome back. National Health Insurance, that's what we're talking about today. We have Minister Tufton on the line. Dr. Tufton?
Hi, how are you, sir?
I'm good. Thank you so much for joining us.
Afternoon.
I know Monday is always a busy day for you.
Yes, but thanks for having me.
You tabled a green paper in 2019, sort of outlining the scope of the thinking regarding a national health insurance scheme. Where are we with it? And perhaps you could, at the same time, give us the sort of bare bones of it.
Right. So we had circulated a document for discussion. We've had a number of consultations. The COVID pandemic has sort of hit a lot of things off the agenda, so we had issues there. But trying now to remount in terms of the specifics of the conversation, I had appointed in my last sectorial Dr. Damian King of the University of the West Indies to continue the work to look at various options. That is still a work in progress, and I'm anticipating taking that information to have more particular discussion. But the general concept is that while we have a no user fee policy, one that was introduced during your time as Prime Minister, the issues around quality of access remains a central issue, in that people, yes, have access to hospitals, but when they go there, do they have the CT scans and the MRIs and the environment, both for patients and clinicians? And the concept of the health insurance scheme was to improve the financing by looking at a range of possible options, some that would involve the private space and sort of a contribution that could be shared, but not restricting access by the potential or the patient when they turned up at a public health institution. Now, in a sense, we've been doing some of that. I mean, we have the National Health Fund, which you're quite familiar with, which provide a range of services, including subsidized services on medication, as well as free if you go through the health system. We have started since the last few years introducing the concept of the public-private partnership arrangement, where the government uses the private sector, where those equipment and other services exist, to support public patients, but where the government pays for that, not the patient. And that has worked well to a large extent in the diagnostic area, because that's a big gap in our hospitals now. In fact, we have served over the last 2+ years almost 120,000, I'm told, cases in private entities that the government pays for because for one reason or the other, the persons who go to the public system weren't able to get that service, like CT scans, MRIs, and so on. How we consolidate that around some sort of financing arrangement is the big question. There is a view in some quarters that health care costs have escalated so rapidly in recent times that it will almost represent a bottomless pit, if you will, if you were to guarantee all the various services. And that is a point of contention. There is a conversation now taking place with the World Bank in terms of the cost that is required based on the demands and the population, as well as hopefully with time with the Ministry of Finance to see how we can structure an arrangement.
Well, I wanted, if I could interrupt you, Minister, I wanted to see if you could help us to put a number on it. Your ministry right now, based on the figures I looked at over the weekend, your ministry is spending $70 billion directly to provide health services through the hospitals and so on. That's not the total cost of the ministry. That's what is, by what I saw, that's what goes to the regional health authorities.
Right.
Right. Have your people been able to sort of put a number? What additional amount would we need in order to provide universal health care to everybody? Everybody would be able to walk into a hospital and get the CT scans and get the MRIs and the medicines. Even if there's a co-pay cost, a nominal amount that they may have to pay. Has that figure been identified?
Well, that's the work that is now taking place to try and come up with a figure, which clearly is a moving target because each year that changes depending on what the cost of providing these services are. So we're talking with the World Bank is doing some work at the request of the Ministry of Finance. We're weighing in on that conversation, and we have also engaged our people to assess. I can't give you a figure except to say that we are seeing costs certainly coming out of COVID going up as high as 15-20% over the last few years. Now, some of that is due to logistics issues, production slowing down, issues around equipment and supplies and so on. But so it probably would be less than that. But nevertheless, you almost expect these costs to go up in each year, given the demands on the system, because it's all linked to the sick profile of the population. 70% of our population die from lifestyle-related diseases, NCDs, and those continue to rise. Cancer treatment is the fastest growing segment currently, even though cardiovascular disease is the most common cause of death.
And therefore, what you're saying is that whatever the source of funding is, it will have to be agile enough to respond to increasing costs.
To those increasing costs and changes. But there's also another element to it, which is a demand supply issue. How do we also institute a program that focuses heavily on primary health care? Because that is where the prevention message and where you influence health-seeking behavior lifestyle can then reduce the cost later on when people go to hospital where, as you would say, the horse has gone through the gate and you have to now deal with curative measures, which are very expensive. So we have tabled a document around primary health care reform that was tabled last year. We are now putting that in place. And essentially what that means is building out more community-based health centers, improving the staff complement at that level, doing more community outreach, supporting things like screening, annual screening, so we know whether someone has a high blood pressure and then would have to adjust their diet or exercise before they get a stroke. Because when they get a stroke, then the cost increases exponentially. So the strategic plan we have looks at it in a holistic way to try and stave off demand, which is growing because of lifestyle-related ailments, lifestyle habits, through primary reform. And then at the secondary level, to address the issues around curative measures, which means building out additional hospital space and equipping those space with equipment and with personnel.
You mentioned before the importance of primary care in terms of, a preventive approach. And give credit to you. I mean, you have been a loud voice, almost crying in the wilderness about lifestyle changes. The problem is that we had tough, sir.
Well, it is a real issue. People don't realize, they don't accept that they can stave off or prevent or reduce the need for hospital care and the importance of that until they actually need it. But we're making progress. We're making progress in a couple of ways. One, we're pushing forward with a nutrition policy in schools because I certainly believe that we have to start with the youngest cohort.
We discussed that on this program a few weeks ago with your Minister of State.
Right. That's critical. So we're collaborating with Ministry of Education. We have the green paper. The consultants are now working, having completed the consultation, and that will form its way into policy, which then will drive things like the nutrition agenda within our schools. Now, the truth is, if a child grows up drinking water and doesn't feel inferior in doing so, as opposed to a branded sugary drink, that carries with the child through life. And that's a good thing. That's a good lifestyle habit to develop at that level. That's the best place to develop it.
Less chance of obesity and hypertension and so on.
Exactly. The same applies to work we're doing now around baseline studies for salts, sugars, and fats. So we did a study on trans fats, industrialized trans fats in our population. We have now gotten to the stage where we've gotten industry, Manufacturers and Exporters Association, to agree to the elimination of industrialized trans fats in our food system. That has been banned in the US, it's banned in Canada. We still have it here. And it is one of the leading cause of cardiovascular related diseases. This hydrogenated, industrialized produced fats that are used in some of the food production process. So we have a timeline of for the next 2.5 years. A committee has been formed. Essentially what that will mean is that if we eliminate that ingredient out of our food system, it will provide a better chance of persons making a choice around the foods they consume without having that potential side effect.
And ease the pressure on the health facilities.
Exactly. So a lot of people don't make the connection between some of these measures, unfortunately, tobacco legislation, all of that, alcohol abuse policy, green paper that we're working on. But the truth is, if we don't deal with the demand side for healthcare, the cost will only get higher. So we have to incentivize and drive behavior by putting in place an environmental framework so people can lead more health-seeking lives.
Minister, you're being heard in New York as well. Can I just hail up Beauregard, who anchors up that side for me? Bo, are you there?
Yes, Mr. Golden. Good afternoon, sir. Good afternoon, Mr. Tufton.
Hi, how are you?
How is New York?
Cold today, sir. Last week we were in the upper 80s. Now it's back to the upper 50s. And it's going to be cooler this week as well.
Your weather is as mercurial as anything.
Yes, sir. We got a sneak peek of the summer, but not
good to hear you. We're talking about national health insurance today, Bo, and I know that is something that a lot of Jamaicans up there would be interested in because they have relatives and particularly elderly folks here that they have to worry about, no?
Very much so, sir. A lot of people are wondering why we don't have free health care.
Yeah, well, we're exploring that.
All right, sir.
But good to hear you, Bo.
Yes, sir.
Minister, you spoke about primary health care from a preventive sort of point of view. But there's another issue that I wanted to raise. Mm-hmm. When I go to public hospitals, a whole heap of the cases that I see there, no business in no hospital, Somebody drop off a mango tree and then spray them ankle and them end up at hospital. Right. When I was growing up, I was fortunate. Right across from my house was the Old Harbour Health Center. Mm-hmm. And, if dog bite you, that's where you go. You go to the health center. Nurse Douglas was always there because she lived on the premises. Hospital should really be for the kind of cases that require that level of attention, no?
You're right. So you're right. Part of the challenge over time is that we have the primary healthcare infrastructure has lost credibility. So people bypass those facilities, the health centers, to go directly to the hospital. interesting. We had a thing like this last week about the 60th anniversary of Bustamante Hospital for Children, and the case was being made by the SMO that people travel from Montego Bay to go to Bustamante or from St. Thomas when some of the problems that they have could easily be solved where they are. And then when they get there, they have to wait because the triage process says you're not an emergency, and then they complain. So the way around that is to restore credibility around the community-based interventions. And we have the ecosystem, we have the basic infrastructure to do that. So when we talk about adding more doctors and nurses to primary health care, improving the facilities so people can wait with more comfort, having more outreach into the community for screening, mobile outreach, visitation at homes, that's really what we're trying to do. And we now have the blueprint for that. And that's what we're embarking on. And one of these programs, we can explore that.
I hope you're planning to incentivize it, you know what I mean? If you said to a doctor, for example, that, look, if you are prepared to go and live and work in the rural areas, well, we write off your student loan. But you have to agree that you're going to work in the rural areas for a minimum of 5 years or whatever it is.
Right.
I mean, really, we have to talk about things like that. You know?
I agree. You have to think out of the box. I mean, the same applies for how you train advanced nurses, where we have a major issue. But you're right. I mean, we have to incentivize both the clinicians, but we also have to incentivize the patients for using these facilities.
Minister,
so,
the heavy bullet that we may have to seriously consider biting. And you're a politician, I'm a retired politician, so I have more flexibility than you in talking these things. You are spending $70 billion directly through the health facilities to provide health care, and no user fee policy and so on. But that money is not sufficient to enable you to guarantee that when a patient needs an MRI or a CT scan at Port Maria Hospital or at St. Anne's Bay or at Mapen Hospital, that facility is there. A lot of the run up and down that the ambulances seem to be doing is really moving patients from one hospital maybe to KPH or to University Hospital because they can't provide the services. Now, 70 billion is what the budget provides for you. Now, you mentioned the National Health Fund. When I looked at the numbers from the special sin tax, the tax on alcohol and cigarettes and so on, plus what comes in from the NIS, I think they pull in about 10 billion a year. But you need much more than that. Are we not going to have to consider, same way that you have an education tax, although that lacks transparency? A lot of people say that money don't go into education. It does go into education, but because it goes straight into the consult fund, it lacks the transparency that I would have much preferred to see a system where, you know, the education budget is funded from what the government can provide, plus what comes in through the education tax, so that people could understand it. But are we not going to have to consider a similar tax? The education tax brings in, I believe, last year brought in $49 billion. Which is why I was asking you how much money you would need to provide this universal coverage. Are we not going to have to seriously consider that? Let me just take a break and you come back and you give me a response to that.
Okay.
Welcome back. It's Jamaica Live. We're on Bridge 99. We're talking to Health and Wellness Minister Dr. Christopher Tufton about the thinking that his ministry is pursuing towards the National Health Insurance Scheme. Minister?
Yes, thank you, Mr. Goulding. So the simple answer to your question is that the money has to come from somewhere. And while as a policy, governments, and this one included, has been not very warm towards the trend of having dedicated taxes, whether it's dedicated or not, the truth is, as a society, you're going to have to contend with a lot of discontent if people want health services and can't get it. Health is a very emotional issue. A sick child, terminally ill mother, or father, or brother, whatever, generates a lot of emotion. And I've been in this thing for 7 years. I've seen it and experienced it, and you have to manage it very sensitively. So,
are we living longer? We need healthcare more.
Sorry,
we're living longer.
And
the longer we live is the more we're dependent. I made the point earlier in the program that over the last 30 years, the population 60 and over has increased by 50%.
That's the point.
I was surprised when I saw the numbers.
So what we're going to have to do is attack it in a very holistic way by managing demand, which is what I've mentioned around primary care and starting with the young. Then as we go through the cohort through to retirement, we make provisions, and those provisions have to be a combination of what we can provide in the health space, what we can encourage in the private space. I hear you say you're going to be speaking to Chris Zacca, but there are a few private hospitals that have been coming up and offering services, and where we can combine our efforts, we have an open mind around that combination, because health has to be viewed as one health. Now, the funding of that will have to be mixed, clearly, because you have representation from private and public and a kind of hybrid. And then the policies to support the kind of wayward behavior that could lead to a fast tracking of an illness that would cost a lot. But yes, the taxes, the dedicated taxes to health will have to continue to increase because of the demands. Should it be a dedicated tax? That's something that I think government policy will have to determine and over time. But there's no doubt about the increase. Now, incidentally, this government health is now number 3, I think, in the overall allocation of the budget, from about number 6 when I became minister 7 years ago. So the government has been faithful to improving the amount. I think we're 113 billion now, about 4.5% or so of GDP. We have a 2030 vision plan for 6%. So we're moving in that direction. So there is a commitment, I believe. There's a massive infrastructure build out. There are more doctors and nurses have come on to the status with security of tenure, and with the build out taking place will be done at Spanish Town, St. Anne's Bay, Maple, and other places, you will see more persons coming in or certainly being offered jobs. The bottleneck will be getting the personnel, and that's a whole new conversation. The demand on health services are very high on health personnel.
Well, Minister, it's an important issue. I think we need to have a real robust conversation about it. I want to thank you for joining me today. I mean, we only scratched the surface, and we perhaps will have to return to it, but it's an issue that I'm going to keep focus on this program. So thank you so much for joining us.
Not at all. All the best. Thank you. Bye.
That was Dr. Christopher Tufton, Minister of Health and Wellness. So we're very pleased to be joined now by former Leader of the Opposition, former Minister of Finance, Dr. Peter Phillips, who he spoke in an interview recently about our progress in terms of fiscal management and debt reduction and so on. And he made a very important point that as good as that is and as necessary as that is, we have to keep working and we have to focus on the things that will propel us forward. Our future is not just coming out of a hole, but climbing a tree. And he mentioned education, so that we can improve our technological capability. But he also mentioned a national health insurance as something that ought to be considered. And I specifically asked him to join us today to give us his thinking on that. Dr. Phillips, welcome to the program.
Thank you very much.
Thank you for coming on again. We had you on before, and I'm so pleased to have you again.
Yes, my pleasure. Greetings to you and your listeners.
Good. And you're being heard in New York as well.
Okay. Well, that's good.
What are your thoughts on this issue what are your thoughts on this issue of health insurance scheme?
Well, I frankly think that's the only way we're going to be able to manage the provision of secondary care, which is hospital care, mainly to the population. Because put it simply, the hospitals need to manage the economic cost, need to recover the economic cost for the services which they offer. In the absence of that, we're going to have the situation like we have now, where you have the hospitals, but they're either the X-ray machine not working, or the MRI, or the various bits of equipment, just in the public hospitals, not working.
One of the issues I raised it with Dr. Tufton a while ago. One of the issues that has to be dealt with, is the hospitals are overloaded with cases that don't belong there. A scorpion bites you, and you rush to the hospital.
Yeah, I heard him make the point that you have to build out the primary care, that's the clinics mainly, and that has to be built out. And quite frankly, we're going to have to also encourage a lot of, find ways to integrate what I might call the private component of healthcare delivery along with the public component. There are things that we can do to make even the private care be delivered more effectively. But what you have now, to go back to the national health insurance question, is that you have about close to 20%, if my memory is correct, of the population which is now covered with health insurance that allows them to go to a hospital and get some coverage. Varying levels, most of them have been negotiated by trade unions or staff associations on behalf of the workers. I think that the government can help for a future by, any government, by really mandating that companies of a certain size need to have health insurance paid for by both the company and the individual. And if you can get, the higher you can get that number, then you're going to have to accept that the government is going to have to guarantee for people who fall below that threshold. People with the destitute and people who may be on the...
people in the informal sector.
People, some of them,
the sidewalk vendor.
Provide whereby they can pay for themselves, and you can do things like negotiate terms with insurance companies so that people, even in the informal sector, many of them can pay if you have it like a partner draw where you can pay for it over, some amount each month, but we have to get creative ways. And then you to allow people who can afford it to buy into it, and people as part of a pass program or something, people will have to be registered and paid for by the state.
But the problem we run into, Peter, take the National Insurance Scheme, for example. The provision was made from the very outset that those people who are not in formal employment can register as a self-employed person. And you go to the post office with, I don't know if it still operates, but you used to go to the post office with your card, and you buy the stamp and you put on the card, right? Now, the response to that was very poor, which resulted in governments having to introduce things like the PATH program to take care of some of them old people who don't have no means of support.
And a particular category of persons that are, as you say, in this case, the elderly. PATH is taking care of young children and mothers with young children in particular. But do you think that we did our best, all administrations, to really market the NHS? I suspect that we haven't. You have other countries who have had national campaigns. Singapore comes to mind. And they really do it urgently. You can go in communities and do much more to register. Our own health services, to use an example with the community health aides, have often done a lot to go and register, young young mothers and people in need of special care in communities. We haven't quite done those things. I mean, even with the drug for the elderly, while you have a greater take-up, we still have people who fall through the cracks, and in these things, we're going to have to do a lot of it like how we used to do enumeration when we used to do it for elections, going house to house, how they're doing the census.
I'd love to get my hands on a figure. Minister wasn't able to provide that figure. He says he has a team working on it. I would love to know, in addition to the $70 billion that the ministry provides to the regional health authorities, in addition to the $10 billion that is collected by the National Health Fund from the syntax and from NIS. And that was a good program, introduced during a PNP administration of which you were a part. But it provides significant relief to people, particularly in getting drugs for chronic illnesses like diabetes and high blood pressure and so on. But if we knew what the figure was to put us in a position where everybody, subject of course to all the restructuring that needs to be done so that we can try and move as much of the sore foot cases out of the hospitals and leave the hospitals to deal with serious things, no? To put us in a position where the fisherman down in Alligator Pond, the farmer up in Crosskeys, if they get sick and need hospital care, they can walk in with a card and get the care, even if they have a co-pay thing, because they may have to pay a portion, no? But to enable us to install the CT scan machines and the MRI machines and the X-ray machines that we need to make sure that we can give them the care that they. But if we are to do that, are we going to be able to avoid or evade a dedicated tax? I'm looking at the education tax. And I'm salivating because it's $49 billion that pulled in last year.
Yeah, and you know that well, put it this way, I'm not in favor of those dedicated taxes because it sets up a mismatch between the expectations of the public and what it actually provides for. $49 billion is a lot of money, and nobody gave it up, including myself and administrations of which I was a part. But you have the task going forward, but much before and plus.
I seem to be losing you, though, Peter.
Eh?
I seem to be losing you.
But
yeah, that's
are you hearing me?
Now. Yeah, that's better now.
Yeah. But I think that we need that number that you spoke about. What we need to do, what will we need as a minimum to operate the health services, and then we are going to have to bite the bullet of doing more on the primary health care to take out the minor cases and deal with those in clinics. And then we're going to have to find a way of getting more people kind of insured. And then this is where the incentive to get insured comes from. Difficult though it is, you're going to have to say, if you don't have insurance, this is the actual cost that you will have to undertake, that you will treat emergencies. And but this has been studied going back to the 80s. It was studied again in the 90s, and I believe Minister Tufton is doing a study on the national health insurance. I think we have to bite the bullet, so to speak, and start some phased introduction. And it is going to have to be twinned with some sort of recovery, because right now we kind of living in a self-delusional world in saying to people that you can get the care in the hospital, but when they go, they also have to seek a lot of this care outside, whether it is for, X-ray or MRI or whatever. And we are also in the situation where the population is suffering more and more from those kinds of diseases that need the complex treatment, the blood pressure, the risk of strokes, the diabetes and the thing, So it is a illusion to suggest that we're going to provide it all from the budget, because even when you get to whatever budgetary figure that they were suggesting for 2030, I doubt that you're going to meet the cost unless the people who go for the service are going to pay for some of that cost.
How do you
through an insurance
how
scheme.
do you efficiently and equitably determine who can pay and who can't pay? That is what hamstrung the user fee policy, because I know I personally saw a lot of cases where people were deemed to be able to pay. But Lord, I mean, they just couldn't.
They just couldn't. And that, I believe, is not impossible to arrive at systems. I mean, we have had the problem with pass, even where people who think that they should be on it and are told that they don't qualify, and no doubt sometimes we get it wrong. But no doubt also there is some need for many of us to recalibrate our priorities inside of our households and elsewhere.
And you mentioned you mentioned earlier, Peter, the cost of treating these chronic illnesses. My blood pressure tablets cost me about $17,000 a month.
Yeah.
Now, I mean, how does a household help or cope with that?
Yep. No, that becomes an impossibility, and we have to look at some areas of real subsidy. Well, you have the drug for the elderly, which is a targeted subsidy.
Yes.
And maybe we should look at targeting some of the ailments, like the blood pressure and things. And I think there was a particular drug window that tried to do that.
Yeah, well, right now, I mean, the drug for the elderly program, the National Health Fund health card, does provide some subsidy.
Mm-hmm.
But even with that, man, I mean, it
is very high. And
I don't know about you, but when I had a constituency, my constituency day was Thursday. Many Thursdays when I left that constituency office, I have sometimes a dozen prescriptions that people bring to me because they can't afford to fill them. And when I look at the date on those prescriptions, some of them prescriptions are about 3 months old.
Dated, and that's why people just get more ill, But we can do, and there has been great effort and a lot of progress on the drug side. I think we can do more to take out a set of ailments and a set of drugs for treating those ailments and reduce the cost to the user, to the citizen, and we can do more. I mean, we need to look at the purchasing of these. We need to look some more at the utilization of the generic drugs for some of these things. And we need to actually look at whether we can manufacture some of those things here. It should not be difficult. I was struck, and I hesitate to raise it because it was something that was on the table, in my time in the administration. But we still charge duties on a lot of the equipment offered in the private sector, and maybe even government has to pay that, given the rules for all the things like MRI machines and radiation, linear accelerators, and all of those things. And I think we can do a lot to reduce the cost of delivery of some of these services in the private sector as well as in the public sector. You know, we have to do that to a maximum. And then we have to, make arrangements with some of the providers even overseas for some of the terms for the equipment that they offer in their home country. But there are things to look at too, which was being considered about cross subsidies between different kinds of patients. In other words, you have a patient who can pay, and you have to charge them and sometimes maybe use some of what you charge, the full charge of those services, and use it to subsidize in the same hospital people who cannot pay, But these things have to be studied very carefully. But overall, I think we need to be aiming at over some kind of 10-year period, to give us just a sense of a lengthy period of time.
But Dr. Phillips, can you just bear with me? We need to take a commercial break.
All right.
Just for a few minutes. Welcome back. We are on Jamaica Live on Bridge 99. We're talking about national health insurance, a concept. And we've been having discussions with former finance minister, former leader of the opposition, Dr. Peter Phillips. Peter, when I was talking to Dr. Tufton, he puts a great deal of emphasis and perhaps hope in lifestyle changes, reducing the demand for health services. But behavioral changes are easy to bring about. How much hope can we put in that?
No, I think we can encourage it. We can encourage it also, as I know has been mooted, trying to intervene in the schools and take highly sweetened drinks and those things out. I think if you try at the level of the school to help people and their parents understand good diets and to eat healthily, then we might make a lot of progress. But I agree, it's very, very slow, very difficult, takes a long period of time, but essential nevertheless.
Yes.
I think if you look at if you travel the road in the early morning and see all the people walking and jogging and going to Emancipation Park and elsewhere, police officers club doing exercise, progress has been made in some of these areas, and a lot more needs to be done, and can be done too, and it will help. But ultimately, we're going to have to find a way to deliver on the services needed and the pharmaceuticals needed.
Did I get a sense when you were having that discussion with Cliff Hughes? Did I get a sense that what you were saying is that, look, we have to keep that debt reduction trajectory going, but as we free up resources because it is costing us less out of the budget to service that debt, debt is reduced. Were you suggesting that education, particularly in order to improve our technological capability, education and health, would you consider those as the two priorities?
Would be the two priorities. I mean, a lot has to be done on the crime and security. I know the demands there, but I believe that for every dollar you spend on education and health, you will be reducing the need for the extreme spend on security.
Yeah.
Absolutely.
I concur with you on that. We're out of time. Dr. Phillips, thank you so much for coming on today. And
Always a pleasure.
yeah,
Thank
man,
you.
thank you so much.
All the best. Bye.
Yeah, we take a break. Welcome back. It's Jamaica Live. We're on Bridge 99. We're talking about national health insurance today. We had a discussion earlier. Those of you who might just be joining us, with Minister of Health and Wellness, Dr. Tufton. And we just finished a discussion with former Minister of Finance, Dr. Peter Phillips. We're very pleased to be joined now by Mr. Chris Zacca, who is president of Sagicor. And Sagicor is perhaps the largest private sector provider of health insurance, so that his views would be particularly useful to us. And we also have online Mr. Howard Mitchell, who is a former chairman of the National Health Fund, which is providing valuable assistance to vulnerable people in the population in terms of meeting their healthcare costs. Chris Howard, welcome to the program.
Thank you, sir. Thank you. Thank you, sir.
Tell me, the Minister Tufton laid a ministry paper in the House, I think it was 2019, sort of bare bones sketching out the concept of a national health insurance scheme. He explained that the momentum got disrupted because of COVID, but he's cranking up on it again. And I believe both of you have had something to do with the conversation and the discussions going on about it. What would you say are the critical components that would constitute a national health insurance scheme?
Can I go first, Howard?
Of course, you're going to go first anyway, so go ahead.
Bruce, you have to also note that I was a former chairman of the Health Fund before I joined Sagicor too, so it's an honor to be on with my colleague and friend, Mr. Howard Mitchell.
Well, that's useful to know.
Yeah, man. So let me just start by saying that our numbers show that the privately insured people in this country is about 850,000, including the government. Out of 3 million, so call it 2 million people who have no form of health insurance, and I think that's untenable. But it's big. It's a big number.
Well, the numbers you're quoting are even better than I thought. I mean, that would be what, 30% roughly of the population?
28%, including the government administration program.
Mm-hmm.
Yeah. So we paid out over $20 billion in claims last year. So it is not a small nut or an easy nut to deal with. But what is clear to us at Sagicor is that it is an extremely important, or goal for the country to have some level of health insurance for the entire population. And my view is, our view at Sagicor is that the best way to approach this is a public-private partnership, which involves, the private insurers, their databases, and entities such as the National Health Fund, for sure.
Howard?
I think I support what the points that Chris has made, Bruce. I think what is important is that our healthcare, at present, with the best will in the world, is missing the underserved. The persons who are at or below the poverty line. And I think that we have to get that data straight. We also have to understand that even the National Health Fund, with its subsidized medication, is still not reaching those people in the way that it should reach them. And that we have to look at how the clinics function. We have to look at ways to move them back out to the hospital because they go to the hospital if they have a headache. And we have to find a way to record their presence, to identify them so that we can protect them. Because a big part of the problem is that those people are not within the official record database. And we have to capture them. The best way to capture them, in my humble opinion, is to try and make the clinic system, and the current Minister of Health and the one before him has done a lot to do that. The clinics have been improved to some extent, but we have to get people going to their clinic in a manner that we can then record what is going on. The other aspects of it, the final aspect, is who is going to pay for this. And I think a big important part of it is to reach out with the educational transformation to get these people aware that their health is their responsibility. The ministry is moving in that direction, but a lot more needs to be done.
Well, let me back up some of what you say. There's no question at all about it that we need to move out of the hospital a lot of the cases that go there. Scorpion bite you, you run to hospital. You know? You drop off a mango tree and you spray in your hand, you pack up in the hospital. Hospital's supposed to deal with hospital business. Which means that I made a point to Dr. Tufton. When I was growing up in Old Harbour, right opposite from my house was the Old Harbour Health Centre.
Yes.
And Nurse Douglas lived on the premises so that if you drop off a bicycle at 11 o'clock in the night, you go wake her up.
Yes.
And she dress you. And so we have to get there. And then, of course, Minister Tufton is putting a lot of emphasis on lifestyle changes, which will require behavioral modification. I believe that, and they're targeting the schools now with a new program. I believe that we have to focus on the next generation, no? And see if we can get less of them coming down with hypertension and obesity and things like that. But
the fact is, Bruce, that because the community has broken down, a lot of the services and the ways that the community could help itself have also broken down.
Yeah.
So I think if we can try and restore that, at least at the clinic level, it would take a lot of burden off. And anyway, that's
yeah, I agree too. I want to say though that the private sector have jumped in a big way to join with Dr. Tufton to promote wellness in the communities. And, you know, again, I think it's an example of how we can live with each other.
I want to do a back of the envelope calculation based on the numbers that Chris quoted a while ago. You said that, I'm assuming this is the entire private insurers, that they paid out $20 billion last.
No, that's just us.
That's just you?
Yeah, so you have to say about 30 now.
30 billion, and if you take all the other insurers?
It, roughly, yes.
Yeah, okay. Well, that is interesting. And you said that relates to, that correlates to coverage of about 800,000 people.
850,000 roughly.
Right.
The biggest chunk is drugs and lab services, and then you have hospitalization, and then you have primary care visits.
So what I'm saying is, if you had, that's 30 billion. If you had an additional 60 billion, then we could have covered everybody, don't it?
Yes, but we could also find ways to bring down the costs of services.
Yeah.
So, for example, a lot of our hospitalization costs are related to private and UW, University Hospital benefits, which if you had a system that was not free but had certain costs associated with it to a lower, you would have probably a lower per cost.
Good point. But the back of my envelope can accommodate all them whole numbers there.
Gentlemen, can I just
hold on, Howard. I want to focus both of your minds on something. Over the weekend when I was preparing for this program, I looked to see what the education tax brings in. Last year, ending March, it brought in $49 billion. That's education tax, right? Now, education tax has been plagued by concerns because of lack of transparency, you know? It goes straight into the consult fund rather than going directly to education expenses. It ends up being spent on education, you know, but the transparency is not there. Now, governments, present and past, don't like this idea of dedicated taxes. But if you're going to, I like Chris's idea about a public-private partnership. But if you're going to ensure that public-private partnership can provide coverage to the lady who is selling banana and oranges down at Harper Tree right now, so that she would have Sagicor health card, for example. If that is to be done, you're going to have to find whether it is 40 or 50 or 60 billion dollars to support it. You can't do that without a dedicated tax, can you?
I don't think so. I don't think so. But can I just say, gentlemen, that before you start doing the back of the envelope calculation and working out the dollars that you're going to throw at it, can we consider that much of this expenditure could be reduced if we could organize the management of our health system better? Because a lot of the money that is spent now is, in my humble opinion, not spent properly. It is mismanaged.
Well,
with the best will in the world.
I'm not going to take issue with that. I'm sure there are a whole heap of inefficiencies there that need to be dealt with.
Yeah,
but at the end of the day,
let's remember, Bruce, that Dr. Tufton has appointed Damian King and a team to kind of do more than the back of the envelope. So I think it will be useful.
So they need to have a mandate to do a management evaluation as well, and to look at the critical areas of expenditure. But the fact is that I support the idea of some sort of allocation of our activities, the cost of our activities, from maybe a dedicated tax or some kind of levy on something. Because that has worked for the National Health Fund.
Yeah, that's right. I mean, the Health Fund, I believe, pulls in about 10 billion a year. Now, what I want to be sure about, you see, is that we need to be clear in terms of what we're seeking to achieve. So many of the programs that we have instituted over many, many years, National Insurance Scheme, for example, National Housing Trust, it takes the easy route of capturing the people in the formal sector, no? But if you're talking about health, it has to involve everybody. Whether it is on the basis that they're going to have to contribute something. The person who has a Sagicor card, when they go to the pharmacy, don't have to pay a portion of the cost of the drugs, you know?
Yeah.
Whatever. But we have to make sure that the farmer up in Matney or the fisherman down in Alligator Pond, if he needs a hernia operation, he must be able to go to a facility, and that facility must have the MRI machines and the CT scans and the X-rays and whatever it is, and the trained doctors and nurses. You know, I was responsible for removing user fees, and removing user fees provided access, but it didn't speak to the question of the quality of the service you get when you go there. So I don't know that we can avoid, much as Dr. Tufton didn't warm towards it. Well, I shouldn't say that. But he said that governments generally don't like dedicated taxes. They prefer to take it through GCT and it goes into the Consol Fund. I do feel that you have to find a way so that that person in Give Me a Bit can have a card. And that card is going to have to require that him pay something and the government pay the balance. And we're going to have to get tough. We're going to have to say, no, look, don't bother turn up at the hospital unless it's a medical emergency. Don't bother turn up at the hospital without your card and believe that, boy, you know, we're going to give you a bly and take care of you. You have to understand that in the same way you find the money to buy the phone card, you have to find the money to contribute to a national health insurance scheme. Is there anything wrong with what I'm saying?
No, not at all. But devil is in the details. I have thought, you know, I chaired the first committee of the National Health Fund that looked at health insurance under Dr. Tufton's administration as Minister of Health. And we were going down a road of looking at the possibility of a tiered system where those who are privately insured are known in a database to the system and they don't benefit from the system. The people on, let's say, use pass as a measure of unaffordability of any particular health care or health insurance. They would get a very low or zero rate, And then the middle of about, let's say, 2 million, 1.5 million people would pay something towards health insurance that was also financed by government on the other side. So that was the kind of bare bones boost that we were thinking about.
But again, the mechanism always is that's what
yes.
fails us.
I don't personally favor.
I mean, for example, I did some
new dedicated tax. I must tell you.
I did some numbers on a previous program we had here. PATH covers about 150,000 people. But if you take the poverty line figures that are published through the surveys, it's 500,000 people who are below the poverty line. So it means that PATH, as good as it is, has excluded 350,000 people.
Well, I am including, well, anyway, we won't argue about the numbers. I thought it was more than that, including the children of the people on PATH. But whatever it is, it's a percentage of the population, less than what will be defined by the poverty measures that are done by statin and so on every
does the private insurer, health insurer, those are defined plans? In other words, it specifies the kind of medical issues that are covered. Is that so?
Most private insurance plans cover all medical issues other than maybe pre-existing conditions. But what it does set out is the maximum amount claimable under the coverage for various types of treatments, etc.
And that maximum would range from what to what?
Oh, Lord. That's not something I have in the top of my head, but I mean, we Sagicor in a number of our plans will cover, under major medical, millions of dollars of coverage for a particular illness.
Yes.
On the drug side, there's a limited amount per year, and then it trips over into a major medical, which is a lifetime benefit.
For a national health insurance scheme, Howard, would we be limiting it as we do with the National Health Fund to particular kinds of illnesses and particular medicines? We lost him? We seem to have lost Howard Mitchell. Chris, you still there?
Yeah, can you repeat?
Yeah, you said you chaired the initial committee that was looking at this. Was it going to be confined to specific designated illnesses, or it would have wide coverage?
That is a debate that we didn't land anywhere in a short time. I was there about a year. There are those that believe it should cover primary care primarily, so you go to your local GP, and you cut out a lot of the requirements to go to hospital, as you said earlier. And there are those that say that the real harm is done to people who cannot afford it, who need cancer treatments, very expensive interventions, etc., that save lives.
Yes.
So it's let me tell you, that is a social question that has to be debated and landed on by the society with the government leading it.
Gentlemen?
Howard, you're back with us.
Yeah, I got cut off. I'm trying to pick up what I think what I'm hearing from Chris's point. What we need to understand is that many of the life-threatening illnesses that our poorer people are faced with develop over time, and if they are caught early at the clinic community level, there's relatively simple treatments that can deal with them. For instance, the high incidence of prostate cancer. If those tests are available at the clinic level, you can identify the problem and act on it before it gets to the point where you need a linear accelerator and extrinsic chemotherapy. So I really feel that we need to get back to basics and find a way to restore confidence in the clinic system. In addition to that, there is the issue which you have touched on of the lifestyle diseases. Something like 40% of our deaths are lifestyle disease caused, and they can be addressed. What happens is that the heavier portion of the cost comes about when the illnesses are far progressed. And what we need to do is to try and address those, get the data on that, and stop it when it's starting out.
Well, Chris, you're a former president of the PSOJ. How muscular does the government need to get in terms of the kind of things that are causing so many of these non-communicable diseases? I made a point when we were discussing the new nutrition policy in schools. I made a point that I went into a supermarket one day and I saw some tins of corned beef. And on the label, they said low sodium. So why we don't ban the ones that have high sodium and say, well, if low sodium is available, if you're bringing in bully beef, that is what you must bring in. Now, don't bring in the one with a whole heap of salt. Why we don't really get muscular on some of these things? Why we don't put limits, for example, on the amount of sugar that can be put in beverages?
You're talking to two capitalists, Mr. Golden.
Yes.
Both of whom have been presidents of the PSOJ, and
Yes.
both of whom, I believe, feel that the market must determine what is good for them. However,
But it is the market.
preempting-
It is the market that is producing so much fat people.
I agree. But without preempting Chris's views, I do support additional state intervention at two levels. One, in convincing people to do what is good for them, first of all. And secondly, for those who are vulnerable to persuasion without having the power to resist, either in their pocket or in their head, right? The state has to make some intervention. And it has to be done in a way that the private sector, the distributors, the manufacturers, can still maintain their levels of profit and their reason to exist. So
Yeah.
I do support state intervention. I don't support it with a big heavy stick, because that's not going to work. When creating a black market.
I agree with Howard, Bruce. Also, can there be programs to make more healthy foods more available and also economical? Because a lot of the unhealthy foods, the citizens are driven in that direction based on availability and price, right?
And like everything else, it is part and parcel of a overarching policy framework that we need to make sure that our citizens have access to better food quality, to local indigenously produced foods that are proven to be healthy. We do not have good dietary habits, and this is where the state intervention is necessary to help educate our people. I also feel that our private sector should be encouraged and incentivized to look for solutions that are not as dangerous and toxic to our population and not come from dumped foods.
Well,
The problem is, Bruce, people want to make a profit. That's the problem.
Yeah. Well, I was pleased when Minister Cuthbert Flynn on this program a couple of weeks ago said that the discussions that the Ministry of Health has been having with the local food processors those discussions have been going very well, and the private sector people have been very cooperative in terms of certain changes that need to be instituted. But that is a long way off, yeah. And I'm just concerned if my blood pressure tablets can cost me $17,000 a month. How does the household help cope with that?
It sounds to me like you're not a member of the NHS.
It doesn't sound like that to me, though.
Well,
It sounds like you have to sign up.
no. Well, I have a card, and when I go to the pharmacy, they ask me for the card, and I present it. But that's what it costs me.
Wow.
And that is one tablet a day.
Wow. You see,
And
that's what it costs you. The guy, the little man in the street, when he reaches that stage, he's going to become a burden because he can't afford 17,000 for one tablet.
When I was MP and I went to my constituency office on a Thursday, I would almost certainly leave with at least a dozen prescriptions that people bring to me. And when I look at the prescriptions, some of them are now 3 months old. And they haven't been able to fill them. So they give them to me, and we had a little program, where we were trying to see if we could fill them for them. But
But
things are work that way.
Well, under the current system at the National Health Fund, once it's prescribed by a public hospital, and I assume a public clinic, the drug serve program of NHF is supposed to facilitate a number of those prescriptions that are rather low or free cost.
I don't want to create any problems for NHF, but my blood pressure tablet cost me $2,000 a month. So I don't know if maybe, as usual, Bruce, you have more expensive requirements than me.
Well, I don't know. I take blood pressure tablets and I take anticoagulants.
I think you should.
And between the two of them, the last time I filled that prescription, it was $26,000.
Wow.
But the main point, gentlemen, is that for most of our citizens, the cost of health and the availability of health needs a lot of work. Let's put it mildly.
And I think we need more data. And as again I say, we need to catch the illnesses early so that we avoid the need for the expensive medication and treatment.
The National Health Fund program. What you said something earlier, Howard, that suggests that it is only serving a percentage of the people.
Yeah.
What percentage would that be?
Well, we have 800,000, not we, I'm not there anymore. They have 800,000 subscribers.
Yes.
But a part of the problem is that we're not capturing, we're not getting to those people who are below the poverty line in the most effective way, the 20% of our population. And also that they are going to the hospitals rather than going to the clinics. So when they go to the hospitals, invariably they clog the system and can't get through and they get frustrated. The drug serve program that they have is serving people, but it's an expensive program and it costs the NHF a lot of money to maintain it. Now, in terms of the effectiveness of the drug subsidy, it has been very effective for that strata of the population who can afford to pay anything for the drug. But remember, we have a large percentage of people who cannot afford even $2,000 a month for drugs. That is where my heart hurt me, and we have to address.
In the work that both of you did we lose Chris Zacca?
No, I'm here.
Oh, in the work that both of you did you look at any other country that has been able to kind of climb this hurdle, how they did it, what the effectiveness has been? Is there anything that we can copy?
The answer is yes. There were, in fact, there was a big seminar held at the Pegasus years ago, where examples of across the world. But the bad news, which I took away, is that it is a very complicated and very lengthy process for any country. And very few countries have been able to achieve some sort of universal health coverage.
And expensive.
So I think we need to probably choose some low-hanging fruit and probably, do a limited approach first, see how that works, etc. But again, I would rely on the data that comes out of the Ministry of Health and the Damian King group to really guide my thinking on that.
My experience has been that the countries that have had somewhat more success in setting up a health system that actually is effective are the Scandinavian countries, and it's an expensive proposition. Those countries are heavily taxed, okay? So that the middle
wealthy countries, wealthy that the citizens earn a lot of money.
Right. The middle ground has to be the approach that the ministry is currently taking, which that some people have to be responsible. Not some people. The people have to be responsible for their own health care and minimize the burden and the impact on the community of people. And that, I think, is the one way to get your costs down and to get people aware of and sensitized to an effective health program.
Well, I'm anxious to get my hands on the numbers that you said Damien King is working out.
Yeah, we need a lot more data because both on the actual needs and on the management of our entire health sector and on the expenditures on the management.
I found it very interesting when I was talking to Peter Phillips earlier on, and he of course is cautioning against any easing off of the debt reduction
Yes.
targets. But what he's saying is that as we reduce the debt and more resources become available because the cost of servicing that debt goes down, the two priorities that he says is education and health.
And I support that.
Education in terms of improving our technological capability. He made a very important point that if we don't focus on that, not just education for education's sake, but education to put us in that kind of play field where we can compete technologically, and then health.
No, I support that, sir, because the fact is that a nation is really made up of its people. And if your people are not able to effectively deal with their lives, you could have all the resources in the world, all the material resources in the world. It won't work. We need to get back to focusing, if we're ever there, on our people and getting them prepared to use our resources in the most effective way.
Well, the conversation has to continue. So I want to thank both of you, Chris Zacca, president of Sagicor, and Howard Mitchell, who is both of them are former chairmen of the National Health Fund. Thank you so much for coming on today.
Pleasure, sir. Thank you very much for the opportunity.
Pleasure. Thank you also.
Yeah, we have to keep this discussion going. Take a break.
Bye-bye.
Welcome back. It's Jamaica Live. We're on Bridge 99. We've been talking today about National Health Insurance Scheme. And as I pointed out, it's the subject of a green paper, which Minister Tufton took to Parliament in 2019. And then, of course, we had 2020 and 2021. We had COVID, no? So it sort of disrupted the work that was to have been done. But he says that is being cranked up now. He has a team working on it, and importantly, he has a group headed by Dr. Damien King looking at it in terms of how to finance it, because that's a critical question. As I pointed out at the beginning of the program, healthcare is expensive. Those machines that you need to do your diagnostics, your CT scans and your MRIs and your X-ray machines, and they have all sorts of, things to do, mammogram and so on. Them things cost a lot of money. So those are very expensive things, and in order to ensure that all the hospitals are equipped, in order to ensure that we have the staff, if we don't find a way to pay our nurses better, we're going to keep losing them, Canada will gobble up every nurse that comes out of our training school. America too. So you have to have your health facilities properly staffed with doctors, nurses, and we have to have the specialists. Not any doctor can treat every ailment. So hospitals are going to need your pulmonologists and your cardiologists and your orthopedics people and so on, and have them in sufficient numbers. And then we discussed as well the importance of restructuring the services that are provided. I made the point that there has been almost a collapse of our primary health facilities. Collapse may be a strong word, but I think Dr. Tufton said that people have kind of lost faith, lost confidence in the primary facilities. So the simplest problem you have in diarrhea, you run to the hospital. You get cutlass trapped on your foot, you run to the hospital. That's not what hospitals were designed for. Hospitals are for secondary and tertiary care. Where you're talking about serious problems, emergencies certainly, but you're talking about serious illnesses that require the kind of attention that is given at a hospital. So one of the first things that has to be done is that we have to rebuild our primary facilities, rebuild both physically, but also in terms of providing the staffing. I made the point that when I was growing up at the Old Harbour Health Centre, Nurse Douglas lived in a cottage on the compound. And it's not one or two times that I know I went over there late in the night because I dropped off a bicycle and scrape up myself. And you knock on our door, and she was always willing to come out and open up the clinic and dress you up and send you home. We have to get to a stage where these rural facilities, particularly rural ones, are well staffed. Doctors must be there on a regular basis, if not every day. I even suggested that we need to incentivize it. I see nothing wrong with saying to a medical student who graduates from university and is now qualified to practice that, look, if you are prepared to work and live in a rural community and work with the ministry and you could be assigned maybe to 2 clinics. So you are at one clinic 2 days a week and another clinic another 2 days a week. If you are prepared to do that, then, we will forgive your student loan. So, you borrow this whole money, which you have to pay back. We will write stuff each year by year, so long as you continue to work in the government service. And the same thing for the nurses. But we have to rebuild those facilities, both physically in terms of the physical surroundings and the quality of the facility, but also in terms of the quality of the service that they offer. And we have to try to see if we can get people now, don't want to run to the Maypen Hospital or the Mandeville Hospital or the Savlamar Hospital. If what you need is diarrhea you're having, go to the clinic. If when you go to the clinic, the doctor there suspect that this is something far more serious, then we rush you off to the hospital. We even have an ambulance ready to take you to the hospital if that is what you need, or we call the ambulance. So if you did that, you'd ease the pressure off the hospitals and enable you to reallocate some of those resources in terms of providing equipment and providing more of the facilities that we need. It is this kind of thing that we need to consider when we're talking about a national health insurance scheme. But then too, we have to deal with the problem of the drugs and access to the drugs. And we have to deal with the problem of how you're going to cover everybody. It's one thing if I say, well, all those people who are employed, you'll get a card, you may have to contribute. I'm not ruling out the necessity that we're likely to have to confront of having a dedicated health tax that goes into a fund that helps to finance the coverage. But we are going to have to deal as well with the problem of how, as I said, the fisherman down in Alligator Pond, the farmer up in Crofts Hill, the barber down at Walton Park Road, the lady who's selling her little cheese tricks and so on the sidewalk down in Crossroads. How are those people going to be covered? The household helpers. So we have to work out all of those details, and it may be necessary to put in a system where if I'm formally employed, it comes out of my pay, a salary deduction, and my employer have to put in his portion. But for those who are not employed, some arrangement is going to have to be made where you go register as a independent somebody, as a self-employed, whatever, and you're going to have to pay some money to keep your card in good standing, so that if anything happened to you and you have to go to a clinic or you have to go to a hospital, just walk with your card. I know people will say, well, you know, people burden them. Can't. Listen, man, suppose you ever look and see what the sale of phone cards in Jamaica is like. The amount of $100 and $200 phone cards that are sold over the counter every day. If people can find the money to buy so much phone card, man, find the money to put on your health card to make sure that you can go to a pharmacy and get the drugs at a cheap cost. And you can go to a hospital and get the services at a cheap cost or free. We have to make up our mind because health is important. And as I said, the older we're living these days, is the more that these things are costing us. It's an issue that we're going to return to because there's so much more about it that needs to be discussed. As soon as Dr. King has provided the information that Dr. Tufton has commissioned him to do, we're going to come back to this program and perhaps have Dr. King here as well to let us look at the numbers. I'm still salivating when I look at the figures that come in for education tax. Let me just tell you what it is. Education tax for last year was estimated to have brought in $48.119 billion of revenue. General consumption tax, that brought in $279 billion. Customs tax brought in $63 billion. Income tax, $251 billion. We may have to look at it, but ensure that it is properly managed, ensure that the money goes directly to the provision of health services, and to make sure that it provides universal coverage. For those persons who, you know, like the lady on the side, for the indigent people, for example, government is going to have to provide those resources so that they can get their health card as well. And that may be something that you do through the PATH program, because, you know, there are people out there, they're old, they're sick, they're not going to be able to contribute to their health care. And that is always the case. You always have a situation where there are some people who have to become a charge on government resources, whereas other people can contribute something towards it. That's what we've been discussing today. We're going to sign off early today. Next week, I'm hoping to focus the discussion on a very interesting topic. Not telling you what the topic is because I haven't confirmed the guests who we're hoping to have. But again, it's one of those things that we have to look at in terms of our future. We're dealing with a lot of current issues, but if the next generation is to be in a better place than the current generation or my generation was, there are certain critical things that we have to do. And there have been a series of articles which have been published recently, which I want to explore when we come back next week. So that's it for today. Look forward to joining you again next week, Monday, when we're going to be doing it all over again. Jamaica Live on Bridge 99.